started doing this ECMO training program in our country. ECMO has been my first love, but over the time that has changed to infection once I realized how important it is to control infection. To tell you the truth, our numbers are down by 20%. Despite all our best efforts, our mortality figures have gone up by 20% compared to a place where there is no secondary nosocomial infection. So that much is the outcome, and it ends up with morbidity, mortality. I need not tell you about that. You know it very well. It is our biggest enemy, resulting in economic losses. Our results could be much better without secondary infection, and physician satisfaction is also lost. So we tend to suspect infection by clinical parameters, white cell count, platelets, C-reactive protein, procalcitonin, and blood culture. Some of them are rapid indicators of sepsis, and others are not. One peculiar factor in our country is the platelets. We tend to see thrombocytopenia quite often in our country compared to anybody else. I don't have any direct answer to this. Why does it happen in India and why not outside? I have been looking after Asians outside the country majority of the times, but still this is not a particularly observed phenomena over there. So I have given it as a thesis to one of my DNB candidates here, and she will be completing that within the next 6 months. So, but it is very interesting to see why do we see thrombocytopenia very often, because it has a crucial role to play in the management of ECMO, as well as we need to keep the numbers at a standard 75,000 or 40,000, whatever it is, as we were discussing yesterday. So predominantly the hand hygiene measures are very important. It has to be meticulous hand hygiene, managing the environment infection free, changing the way we do things, have thorough introspection and change the way we do things. Antibiotic de-escalation is extremely important in reducing multi-drug resistance pattern. With no blame culture, if you start this practice of having a thorough introspection in your own unit and try to bring practices with an approach to bundle, like you combine few of these measures together, then those bundles will act better than one individual parameter. Examine the effectiveness or cost effectiveness of the interventions and use interventions as bundles. So I presume most important problem is the active ingredient of the drug which we are getting. Just to give you a brief example, in UK or USA, if I get amoxicillin or augmentin, it is 100% amoxicillin or augmentin. I can tell you without any problem with that. What happens if the drug companies give you a medicine with 20% augmentin or amoxicillin? Their license will be banned, and that has happened in the past. It will continue to happen. So where are these drugs going then? To quote you an example about one of the companies which has done is Ranbaxy. Their license was banned in United States. They ended up with by paying $500 million, if I am right, as penalty, and those drugs, they were dumped on us. So if you treat a bacterial infection, as it is our problem, if you treat it with a medicine which has got only 10% or 20% of active ingredient, what will happen? Bacteria will laugh at you and they will multiply, they will develop resistance. The more number of antibiotics you throw at them with 10% or 20% active ingredient, they happily enjoy that, and very quickly they tend to develop resistance. So I think it is one of the major problems. That is, the major problem is generic medicine is not important, but what is important is active ingredient in that particular medicine. It should be good enough. I think we all need to take it to somebody, whoever is responsible for making these changes, increase the number of true drug inspectors who can really do pharmacoanalysis and decide about the content of the drug. Is it possible is a question, and I will leave it to you. Not only this, there are plenty of medicines available in the market, they are called fake medicines. You know, probably this is a multi-billion pound or dollar industry which is going on in the world. Fake medicines, dumps and dumps of medicines are being manufactured anywhere in the country. May not be not only in India, in other countries as well. They are manufactured. That's the outer sheet will be the same, but internally what you have is either a syrup or what, sugar water, or in the capsules, or it could be a piece of chalk. It has been found out. It's not a story, and it is true fact. So if I go to pharmacy and ask for a medicine, I have a equal chance of having a true medicine or a fake medicine. We don't have any control on that. So if we are trying to kill bacteria with fake medicines, what will happen? So this is the dilemma we are facing. That is my hypothesis, at least. Probably true, but that is that many of the times we don't tend to do drug levels. Though doing drug levels is important, many of the times we tend not to because of various reasons. The toxicity of the medication, we had a genuine question yesterday about the pharmacokinetics. Yes, if you are using a medication like gentamicin in higher doses, probably that will result in a nephrotoxicity, because on ECMO you need to reduce the dose and increase the dose of gentamicin. The other most important factor is de-escalation. All of us have concerns about infections, so we start antibiotics. But how long is the question mark? If you give a subtherapeutic medication for a longer period of time, that is a problem. But even if it is a therapeutic medication, but if you are giving it for a prolonged period of time, again drug resistance tend to develop in those cases also. So though you have started a medication, after culture results or clinical behavior of the patient, if you can analyze and stop, that is de-escalation of the medication, that will reduce your bacterial resistance to a significant extent also. Here, we all need to work as teams, cardiac surgeons, intensivists, ECMologists, anesthesiologists, everybody have to work as a team. If I am stopping a medicine which was started by my colleague, it is not because of my rivalry with him. There is a reason behind that. So all of us need to agree on that. The good intentions need to be agreed on and continued with that. So when that is possible, yes, we can reduce the infection rates. At one time in our nursery, we were having exactly the same sort of situation as the rest of the country is facing. But by sticking to these principles, as I was fortunate to have my colleagues who understood what I am proposing, in 3 months' time, we were able to bring these changes down. The multi-drug resistance, first we started to get multi-sensitive sensitive bugs, and after 3 months, those bugs disappeared. We were getting an occasional organism coming from outside. This was proven in cardiac intensive care unit. You may not have a lot of field for infections coming from outside your own unit because they are already infected, but those clean cases which you tend to see in your unit, you can change the biological characteristic of the bacteria by doing your own procedures. Due to lack of time, I don't want to escalate further on this. Fungal prophylaxis is also very important. In UK, we tend to give nystatin as a routine local agent of a local application. It has helped us to keep fungal infections down as well. And so when we are treating our patients with subclinical doses of antibiotics, it is very important to use some of the agents topically. I'm just talking about topical administration to keep the fungal growth low as well. So they're so important because they decide the duration of our ECMO, need for thorough introspection, and it decides about success or failure. Infections, actually, when you get a nosocomial infection, your ECMO course will get extended by at least 1 week in the best possible situations, and it has got so much of financial implications for the patient and for the hospital too. Common infections are gram-negative, next gram-positive fungi, multi-drug resistant strains, and viruses. Bacteria have got their own beautiful way of talking to each other, communicating with each other. and transmitting resistance by means of plasmid mediated mechanisms. So they are very, very intelligent organisms, and it is very difficult to beat them. So there are friendly bacteria and pathogenic bacteria both. So think about the friendly bacteria as well. You may need to supplement friendly bacteria sometimes when your antibiotics kill all the bacteria. Quorum sensing is the word. When you go home, I'm sure you are aware of this, but if you type this word in YouTube, you will see beautiful videos. Quorum sensing is the language of bacteria through which they communicate with each other. It is very, very beautiful. So you can watch this on YouTube. Biofilm formation. In other countries, we don't worry so much about the biofilm, but probably in our country it might be still useful, because from when everything is important, you might be able to prevent propagation of biofilm further when you are continuing for longer period of time. Using antibiotics for chicken and other animals, that is also as growth factors that have ill effects on our own health as well. As you know, when you are using indiscriminate antibiotics as growth promoting factors for chicken and on cattle, multi-drug resistant organisms tend to develop over there, and you consume the same multi-drug resistant organisms with forthcoming adverse events. So washing hands is very, very important. Washing under water with soap and water is also important. If you use any other material as bacteriostatic or bactericidal material, that will be useful as well as alcohol, but most important is soap and water. But in between patients, just application of alcohol is extremely important. Alcohol with chlorhexidine and alcohol without chlorhexidine, those are the two proven methods to keep your hands free in between. There are drug-resistant bacteria everywhere in our country. They are there in tap water, they are there in the soil, and the only way to get rid of this water infection from the tap water is by reverse osmosis technique. So our hospital should be providing water with a reverse osmosis technique. If you wash your hands in your intensive care unit with water which is already contaminated with pseudomonas or some of the bacterial infections, you are going to transfer the same bugs to the patients also. So I want you to be mindful of that. Hand washing and drying. Using paper towels is the best way. It will reduce your for drying purpose. It will reduce the transmission rate by 48%. But the worst way is using a warm air dryer. It increases bacterial proliferation as well as dissemination by 250%. So don't use dryers, air dryers in your ICUs. Endotracheal source as the source of infection. Endotracheal tube, yes, it is also proven as such. So please be very, very careful. Don't keep the endotracheal tubes outside when you are using them for intubating patients. Use a sterile tray and keep them in that. You have to be mindful of. There is not one single area. I think thorough introspection is the only one I can say. It will help you where you are catching the infection. Organisms and antibiotic susceptibility. Doing the drug levels is important for that. Okay, this is just one of the examples as colistin, because colistin is the ultimate drug in our country for any bacterial infection. We just stopped there at this point of time. In 2014, when I came over here, I was thinking we need new antibiotics, but after our experimentation with our policies and introspection, I felt if we use our available antibiotics in the most wisely fashion, we really don't need new antibiotics. We can still work with the old antibiotics. This is about replacement of bugs. Majority of the institutions in the country will be having this, like a chlorhexidine, something for hand wash, and it is a cost-effective way of the way we look after central lines at Krishna Institute of Medical Sciences over there. It gives the knowledge, at least, or concept for the nursing team and for the doctors, like central lines are protected and we're not going to use them. You use them just like that for any other medication, and they will be accessed in the best possible way to reduce the infection rate. That also helps. Any other area, just as it is common sense. See how long the water container in this is lying here. What is happening when you need to change it? Is it being autoclaved or just cleaned with water? In majority of the places, it is simply cleaned with water and it goes to recirculation again. So have a thorough introspection. Ultrasound probes. In general, we tend to use ultrasound probes from patient to patient just like this. It can transfer infections from patient to patient. If you use just a glove on the ultrasound probe, when your cardiologist is using, an ultrasonographer is using, and remove the disposable glove after the examination, it prevents transmission of infection from patient to patient when echo machine or cath lab or ultrasound is being used. Simply syringe pumps, people touch them majority of the times. So every day in the morning and evening, they should be cleaned by the nursing team, because these are the areas which are very commonly accessed. Use of disposable gloves for examination of the patients. These are not very costly. I think it is a 1 rupee or so for a pair of gloves, but it reduces the infection rate by 25%. It has been proven. So besides other measures, if you use disposable gloves for examination of the patient, so you reduce transmission of infection rate by up to 25%. And this is one of our patients where dressings were done. You know how, despite their way of doing dressings, etc., so much of material is lying here next to the patient. So very sure if there are bacteria in that, they will be lying on the bed as well over here. So how do you prevent this? These are small things, but they are all very important. In UK, it is customary for everybody to wear a small apron like this, a plastic one. This also costs 1 rupee for each one, 1 rupee each. So, and it reduces transmission of infection from patient to patient, and it will protect you as well. We cannot examine any patient without wearing this disposable plastic apron. So review our situation openly, understand the lacunae, tighten the loopholes, and do further advances. Implementation and review are very important. Thrombocytopenia, I developed my concerns with you. Why is that? Is it organism specific or is it genetic to our population? I will be really grateful if you can educate me in this process. So staff education is very, very important. Specify the staff duties and responsibilities with no blame culture. If you all understand each other and go further forwards, that is the point where we can get some sort of control on the infections. In this process, everybody is important. Aya is very important. You know, don't take them as fourth class workers or third class workers like that. They are extremely important for cleaning the environment. Nursing team are very important. Doctors are very important. So each and every contributor participating in your environment, they are all partners in maintaining this. Nobody is superior, nobody is inferior in this. Antimicrobial surfaces, just a word about that. It has been proven if you use copper as the material for your commonly used platforms, copper kills majority of the organisms, bacteria and viruses to 99% within an hour. We tried this, but our institution didn't go for this from the cost point of view. Cost is there for everybody. In United States, they did try this, and because it is all run through the insurance programs, etc., they have established hospitals with the copper content in all the surfaces, majority of the surfaces where you are going to touch, and they have shown in 3 years' time they got all the profits back, and those hospitals were the cleanest. They got infection control in much nicer way. So they were in profits within 3 months time, 3 years time. They were able to recover all those all that extra investment they put in for construction of these hospitals with copper surfaces. It is something for you to think about it. So I feel if you are just standing in a unit to a corner and see how your colleagues are doing and how your colleagues are helping in controlling infection, probably that is the best advice I can give you to formulate your own policies really. And using them as a bundle is important as well. Broad spectrum antibiotics, yes, discovery of new class of antibiotics, it is on the horizon. Maybe in 5 years time it will come, but probably if we use our antibiotics wisely, we don't need them. This is a little bit about NDM1 spread in India. So no blame culture, understanding each other and going forward. So I have no recommendation where ECMO should be done. Probably my recommendation is wherever you think is the right place for controlling antibiotics. If you think it is your operation theater, as theaters are said to be the nicest places for controlling of infections, I recommend yes, that is the place probably where ECMO should be done. If you are ICU, you can guarantee me that they are the places with all these measures you can reduce the colonization rate significantly down and keep the infection rate low. That is okay by me. But take it for granted, if infection rate goes up and if you don't have any control on the MDR, the program is going to fail. So that is the reason infection control is very, very important. So it is just about zero tolerance to infection. If you all unite together, even the lions also will run away. Okay, thank you very much. Just I want